Okay, I think we'll get started while you're all enjoying the hopefully very tasty lunch. One quick announcement. This St. Mark's fleece was found on the property, so if this is somebody's fleece, I will have it down at the table and you can come reclaim it whenever you'd like. For our lunchtime keynote speaker, we're very privileged and pleased to have Dr. Cheryl Bushnell from the Wake Forest School of Medicine. Cheryl's journey up here has been a year in the making. Cheryl was one of our keynote speakers last year, and she dutifully went to the Piedmont Triad International Airport and waited there for, I think, about 8 hours while the tropical storm led to flight after flight cancellation, and I think she finally gave up around midnight, and it was clear that she wasn't going to be able to come up here. And I think she was thought I was kidding when I told her, okay, well, we're going to pencil you in for next year. But as it turned out, she was very gracious to try again and successfully made it up here. Cheryl received her bachelor's in biology from Lutheran University, and then received her doctorate of medicine from the Medical College of Wisconsin. She also holds a master's in science in health sciences and clinical research from Duke University, where she did her residency in neurology and also her fellowship in cerebrovascular disease. She did her internship in medicine at the Medical College of Wisconsin. Cheryl has a very impressive CV with close to 100 publications. She's authored 6 books chapters. She is the recipient of numerous grants and was telling me about an exciting grant that she is working with right now. One thing I thought was interesting on her CV that I wanted to include is that she, just to show that we neurologists are well-rounded, she is a United States figure skating, silver singles and pairs judge, and a bronze dance judge. So it's not all stroke and neurology. So we are very happy to have Cheryl speak to us this afternoon about stroke in women, sex differences in risk and outcome.
Thank you so much, Lee. It's great to be here. This is a really impressive conference that you put together, so congratulations. So my passion in life is to try to improve outcomes in stroke, and in particular stroke in women, because a lot of times women have been underrepresented in clinical trials and a lot of other studies. And so what I want to highlight today, I hope you take home with you, is the fact that there are differences between men and women when it comes to stroke treatment and stroke outcomes. And I'll get you thinking about what some of the future directions might be for understanding this a little bit better. So these are my disclosures. I have research funding from the World Federation of Neurology and the World Stroke Organization, as well as the AHA and PCORI. So what I'm going to talk about a little bit for orienting everybody, first with epidemiology of stroke and sex differences, talk to you a little bit about some of the stroke risk factors that are unique to women or are more prevalent in women than men, and then give you some data from one of our studies related to quality of life after stroke. Starting with sort of the big picture of stroke statistics and sex differences is that men actually have a higher stroke incidence than women if you adjust by age, but women actually have a higher lifetime risk of stroke, and the reason for this is that they live longer. So women are going to have a 20% risk of a stroke over their lifetime after the age of 55, and men will have about a 17% chance of a stroke. But if you also look at mortality and you look at the number of survivors with stroke and the age span, again, that women live longer than men, you're going to see that there are 30,000 more women who have died from stroke than men. So they make up the majority of patients who die, and they live longer with and without a stroke, actually. So we know that stroke is now the 5th leading cause of death. It decreased rapidly from 3rd to 5th. but it's still the third or fourth leading cause of stroke in women, depending on what source of data you look at. So there are actually more women, again, dying from stroke, and again, has to do with age. If you look at the stroke survivorship, there are 200,000 more women who are disabled after a stroke than men. And so one of the things I want to point out, and some of you may know this if you see patients in the emergency department and evaluate them for acute stroke, is that women actually present with slightly different symptoms than men do. Women are more likely to have pain associated with their stroke symptoms. They're more likely to have some change in their level of consciousness, and they're more likely to have nonspecific symptoms. So how much of this is related to, for example, women being older and coming from a nursing home? Maybe that's some of the changes that we're seeing in terms of presentation. It's not clear, but I think that this is important because it can actually lead to delays in the evaluation and treatment in the acute stroke setting. So I just want to make you aware that there really are some minor differences in terms of symptoms. Now, one of the other issues that has been explored in sort of a theoretical scenario type of research survey is what are the decision-making and risk-taking differences between men and women when it comes to stroke treatment. So this was a study from Canada where they looked at stroke clinics and they were asking them in a theoretical situation, if you were a candidate for IV thrombolytics or if you were a candidate for carotid endarterectomy, would there be a difference in your willingness to accept this treatment? And so, interestingly, women were less likely to choose IV TPA than men. And but there was no difference in choosing carotid endarterectomy. And so the reason for this is probably related to the fact that women were less likely to want to take the risk, and they wanted more information about the treatment before they consented to it. So this is something that is really important in the acute stroke setting if you're evaluating patients for TPA. So again, women were fearing the risks and they needed more information for TPA. So another really important study came from the Greater Cincinnati, Northern Kentucky study. And what they did was study the exclusions for IV TPA and then sex differences in that regard. And so what they found is that eligibility for TPA was similar in men and women, so there was no real difference there. But women were more likely to have severe hypertension, and of course that requires treatment. If you have to have close monitoring in order to be able to still give TPA if they're very hypertensive. And so what they found is that women were actually undertreated for hypertension, and it probably accounted for why they were receiving TPA less likely than men. So very important to understand the treatment of blood pressure in the acute setting. Now, you may know that women are more likely to have hypertension than men of all stroke patients. And so as people get older, they're more likely to have hypertension. We have a growing epidemic of older women in this country, and so you're going to see this more and more often. And so if we try to review, and this has been shown over and over and over, that women are less likely to be treated with TPA, but the other important factor is that women do worse after stroke. And I'll be going into more of this detail when I talk about quality of life. But when you look at men and women, whether or not they are treated with TPA makes a huge difference in their outcomes. So basically, this is a study from Canada. They used the Stroke Impact Scale 16 as their functional outcome. And so a score of less than 75, and this score goes up to 100. For those of you who are not familiar with SIS 16, it has a lot less of a ceiling effect than the Barthel index. And within each level of the modified Rankin score, you can see multiple levels of the Stroke Impact Scale 16. So it is much more sensitive, and it's not subject to the floor and ceiling effects of some of our other common outcomes. So anyway, we have these patients with a stroke impact scale of less than 75, and you can see that women who are treated with TPA, about 50% of them had that, and then without TPA, you can see that men actually did worse. These are women in the dark bars, I'm sorry. So they did better with TPA and worse without TPA. And so if you looked at the entire cohort and you didn't account for TPA, there was really no difference in the outcomes between men and women. So TPA makes the outcomes less of a problem and less of a disparity between men and women. And we also showed this in our own data from Wake Forest. And I need to thank Dr. Lee from Korea, who worked with me for a year and went through over 1,000 medical records in our stroke registry, and again showed the same thing. So women here with TPA did much better than men, and they had a worse, well, actually no difference in outcome without TPA. So it's really a major factor in terms of outcomes. And so this is, and in fact, there was actually a trend toward men doing worse with TPA, which is kind of surprising. So we have a lot of future challenges to really understand these sex differences in outcomes. And we do know that women tend to respond better to TPA than men. Now, there are a lot of factors here, like there could be bias related to the patients who were chosen for TPA. The 2 studies I showed you were not randomized controlled trials, but I'll tell you that even analyses of the NINDS TPA trial showed the same thing, that women did better with TPA than men did. And there you have a lot less risk of bias. But women are less likely to receive TPA. This was true in our cohort as well as many other studies across the U.S. and Canada. And again, probably related to age and comorbidities prior to the stroke that are present. But again, this is still an issue. It's important to understand that women are equally eligible. This is based on the study from Kentucky and Northern Kentucky and Cincinnati. But we still need to make sure that we are treating blood pressure so that women can actually receive TPA. All right, so another thing that's really important is that stroke risk scores have been developed over the course of probably the last 25 years or so. And it's not clear that they actually are accurately assessing sex differences. So these are the risk factors, and you all know these, but these are the risk factors that are for both men and women. The ones with an asterisk are the ones that are actually more common in women than men. And then these are the ones that are unique to women, such as oral contraceptive use, hormone replacement, pregnancy complications, and preeclampsia, gestational diabetes, and migraines with aura. And so these are the factors that I'm going to be talking to you about in a little bit more detail. But the problem is that those are not accounted for in the stroke risk scores that are commonly used. So this is the Framingham score, and you can see that for a couple of these risk factors like CVD, or this prior cardiovascular disease, for diabetes and for atrial fibrillation, that there really are point differences towards the overall score between men and women. So women get an extra point for atrial fibrillation and diabetes. Men get an extra point for cardiovascular disease. So there are differences, but my major problem with this is that it doesn't even start until age 54. And even the newly created cholesterol risk score from the AHA and the American Cardiology, they don't really account for anything under the age of 40. So if you're talking about a younger woman with risk factors, you're not going to be able to get a lifetime risk score with that. So again, just for the same number of points, the 10-year probability is actually lower in women than men. And for a score of 10 points, men have a 10% risk of stroke in 10 years versus women with a 6% risk.